moonlight. Let the people scream. Ain't no need for street light. Ain't no need for moonlight. Let the people scream.
Good morning, everyone. Good morning. Let's make sure we've got the right connections this morning. Let's get this on the road. There we go. There we are. This time I'll press the right buttons. There we go. Let's make sure we are all fully connected. Empress Abina, how are you?
That was a struggle again with my name on your tongue. Struggle again.
You're feeling good, are you? Your volume, going to get your volume up.
My volume is up.
Okay, your volume is up. Keep talking. How are you feeling this morning?
I'm good. I'm back in London, which is nice, back home.
Uh-huh.
So that's really good. Hold on.
Okay, let's get this show on the road with you, huh? Okay, so let's start, shall we? Now then, so this is the Motivator Show, alongside Empress Abina. Empress Abina, how are you feeling this fine and wonderful morning here in London?
I am looking forward to this weekend. I heard it's going to be extremely sunny, so I'm very, very excited. That means a day out with my son again. So I'm looking forward to that. Looking forward to my event next week, the event that I'm helping out with next week in Peckham for people whose children have SEN. So please do come along. I think there's going to be a bouncy castle, treasure hunt, things where children can make, where they can find out more information on SEN, how to get support with SEN. So I'm looking forward to that next week as well. So I'll be doing some work with that today as well. And just relax, try and take the bend.
Wonderful, wonderful. And whilst it's always good to hear the adventures of Empress Abina.
Oh, I don't do adventures. I'm just the mum doing her thing. There's no adventures here. Those adventures stopped about 10 years ago. So yeah.
Oh, come along now. Now listen, don't pay any attention, people. She's a committed member of our community. She's not motivated by hubris, you know. Money is not what motivates her. It's really contributing to the lives and times of the community. That's why she's here, huh? Come on, Empress. I'm going to talk you up anyway. But let me just continue. Let me continue. First of all, I want to give praise and respect to the previous presenter, Ian King, who's taken us from night to day. Ian King, thank you. Thank you for being that stalwart for the community. I want to give praise and recognize the wonderful Galaxy management. Those visionary leaders recognize the importance of our community here in London, possessing media platforms that we control, and therefore our worldview, our opinions can reign supreme. I want to praise and recognize Nana Pakomba-Bai, the founder and leader of GalaxyAfui.net, founded more than 35 years ago. Wow, huh? 1983, I understand. But you know what? We need to get him back on here. We need to talk to him further about the future of this wonderful media platform. I want to give praise and recognize, of course, Dr. Abu Ratata and his wonderful lady wife. I give praise and respect to you. for your dedication to each other and the community. I want, of course, recognize Elder Eric Kruti. Elder, wherever you are, we're thinking of you always. Without our elders, we are all lost. So I want to give praise and recognize Elder Eric Kruti, okay? But I also want to give a special recognition to the solutions finder. I want to give praise and recognize to Empress Shanice, the solutions finder. Okay, she doesn't moan, she doesn't complain, she says focus on the solution to an issue that's affecting our community. Such people are worth their weight, not in gold, but in, of course, computer chips, because that's where the money is these days. Huh? I also give recognize to other members of the GalaxyAfiri.net management. I recognize and applaud you all.
Praise and recognize the wonderful Galaxy management.
Oh, I see we've got the...
Yeah.
Oh, are you saying our sound's not right this morning?
Yeah, sounds like she's whispering.
Oh,
Like
I have said this
not
to
what
her.
she said.
Yeah, I'm going to adjust her volume further. Thank you. I appreciate your call. Don't worry. Thank you, sir.
Mhm.
Did you hear that, Empress Abina? Your voice is whispering.
Okay.
Oh, that's better. Yeah, you've got to stay closer to the mic. Okay. And I appreciate that caller. Always does it for us, making sure the audio is correct. But I also want to recognize, of course, and reminding, of course, of my a regular guest to this show. That's, of course, Ndidi Ichoa, and that wonderful inspired article where she noted it is not Africa's natural resources which is the source of its wealth. It's the technologies that derive from those natural resources. So I want to give praise and recognize, of course, to the engineers, to the technicians who allowed this station to evolve for more than 35 years from I should say, FM radio to digital radio. And now, of course, this program is transmitted not only via GalaxyAfiri.net via digital radio, but also via Facebook under The Motivator Show, DE space Motivator Show. Equally under, of course, YouTube, again under The Motivator Show, and of course, Mixcloud, okay? So you can not only hear us through those platforms, you can see us. You can see the wonderful Empress Abina. She's kind of doing her chin at the moment. Been very thoughtful. There you are. So I want to recognize and applaud all the team members and all those who contribute to continuing GalaxyAfiri.net, an important media platform to spread positive information to the community, to bring the community together. And I want to give praise and recognize all those involved in that venture. Thank you. Thank you. I also want to now just move us along, Empress, and I hope you don't mind. I want to move very quickly into the health section. It's quite evident for the constant feedback I'm receiving. And increasingly, my Empress, you will also receive feedback from the audience that indicate that the health messages are getting through. There's a recognition that we do not need to have above average health instances in our community if we take care of ourselves. And of course, it always begins with what we put into our mouths. So I always remind people that I'm not here to tell you what to do. I'm not here to give you instructions. I'm not here to demand that you do this. I simply ask you, I hopefully reasonably, to consider. Is that right, Empress? I ask them to consider.
Yeah, they need to consider, if you want to live longer for your families, be there for your families. And in the climate that we're in, when health is such a big issue and people are constantly getting ill, you know, we need to look after our bodies. We need to, you know, what you put into your bodies is so important for you, because it's the nutrients, it gives you energy. So if you want to have energy, if you don't want to be tired or lethargic, if you want to sustain living longer, be mindful of what you put in your bodies. And that's not just to the public out there, that's to myself as well. That's to your children. Remember, you know, we're in a town or a city where everything is fast paced. So we want to cook really quickly. We want to just feed, eat, and sit down and do whatever we have to do. But it's very important that we give a balanced diet to our children if we want them to be healthy and last longer, because we know there's a big obesity issue with children in Southwark as well. So, you know, if we don't want our children to struggle with their health as they get older or have heart conditions or, you know, have a shorter lifespan, we have to be mindful of what we eat.
Mm-hmm. So I'm simply going to say to the audience, I ask you to consider the amount of sugar that you ingest into your body, you consume, yeah? You know, do you need to add the additional sugar to your teas and the coffees? Yeah? Yeah. Do you need to consume that many of these so-called tin drinks? Mm-hmm. Do you really need to eat those large chunks of cakes? You know? Mm-hmm. Okay. You laugh, huh?
Because all of the things that you're talking about, I love. That's what I'm laughing. So I do love my ting. I do love my brown sugar in my herbal tea. So, you know, in moderation though, I only have it in the morning. But I do love cake. I'm partial to a bit.
I know. We learn this behavior as children. We take it into our adulthood. In fact, many adults eat as if they're children. And you and I know that we're not physically as agile as we were when we were a child. Yeah. Therefore, we've got to adjust our nutritional intake to suit the time and place we are currently experiencing. Okay. And of course, what we have in our community is significantly above high levels of diabetes. Mm-hmm. Now, clearly in the Caribbean and in parts of Africa, diabetes is a big problem, yeah? Professor Hilary Beckles, the Vice Chancellor of the University of the West Indies, notes that in most, if not the overwhelming majority of family groupings across the Caribbean, and it's not dissimilar here in Britain, there are members of the family with diabetes. Yeah? Or as one of our previous guests would refer to it as insulin, I think it's a term used where you're not reacting to insulin anymore. Yeah, we're not producing anymore. Okay. And that's because we've consumed far too much of it and way in excess of what we actually need. Yeah. So your body has difficulty just getting rid of it. Yeah. And what it does, it accumulates and become toxic inside our bodies and manifests itself in the form of diabetes and other similar ailments. That's the future that we set ourselves up. Yes, sugar is attractive, it's addictive. Actually, it's causing incredible harm to our community. But I say to you, don't take my instructions. Please speak to your nutritionist, speak to your doctor. Let them give you the professional advice. I'm but an elected official, and all I see are the stats, the figures, the actual figures. When I receive my briefings, these are the figures I see. And I see the damage that is causing to the community. And I ask myself the question, we can do better, Empress, yes.
But Demotivator is also about people knowing their bodies and doing research about foods and diets, or, you know, just certain alternatives of supplements and vitamins that they can take as well. It's not about diet as well. It's also about the supplements that you take, like B12, B13, folic acid. Even though people think they're for children, they're also really good for adults. There are so many vitamins that are, like iron is a great thing that a lot of Black people lack as well, because they can be quite anemic. So iron is a very good supplement that we need. So it's also about speaking to your GPs, but also doing your own research as well, because that's very, very important, because everybody's body is different.
Absolutely right. But my Empress, I want to keep emphasizing, you and I are not professionals.
Mm-hmm.
Yep, we can read the facts and details, but that's why I recommend members of the audience who are unsure, speak to a professional, your GP or a nutritionist. They're the ones who are to give you the authoritative advice. We can only indicate to you that this is an issue that definitely is affecting our communities and one that we must respond to. And similarly, my Empress, that I ask the audience to consider the amount of salt that we are consuming. There you are, another laughing. There you go again.
Because I put a lot of salt in my food. That's what I'm laughing. I'm obsessed. I don't even try my food before I put salt on it. I've got like my little Maggi sauce as well, my hot pepper sauce, and I put it all on my food before I've even tasted it.
I know, because...
Don't copy me, audience. Don't copy me. That's just...
Thank you for saying that. Because you understand that excessive salt, okay, is harmful. Maybe not today or tomorrow or next week or next month or next year, but not even in 10 years, but within 20 or 30 years, the accumulated impact of excessive intake of salt in your body, as you get older, you become less, stronger, less able to resist. There you are, yeah?
Depends on who you are.
Oh, of course. Oh, but of course, my Empress, but we all know that hypertension or high blood pressure also pervades our families, okay? It is almost as bad as diabetes, yeah? And again, it's down to our cuisine and our lifestyle, which is the principal cause. So I ask people, please, my Empress, I ask you all, please, to consider the amount of salt we are ingesting into our bodies. Yeah, it is harmful in excessive amount for long periods of time, as you would expect, huh? As you would expect. And as you said earlier on, for yourself and your loved ones, do it for them. Yeah, and I don't say go cold turkey and just stop it overnight. In my case, it was a gradual reduction over a period of 11 years. So now I no longer add salt to my cooking, okay? And of course, when I encounter food with above average amount of salt, I immediately go, like that, and I spit it out, okay? Because it is unnecessary, yeah? Those of us from the Caribbean will recognize, and I know parts of Africa, saltfish, yeah, or salted cod usually, as part of our cuisine, okay? I urge those of us, particularly from the Caribbean, who have that still as part of our cuisine, I want to urge you to stop it, yeah? And if in doubt, because I'm not a professional, speak to your doctor, speak to your nutritionist, speak to a trained professional who understands and is able to speak authoritatively on this subject. In fact, our guest later on may well be the authoritative figure we need, huh? Okay.
Definitely.
Absolutely. Okay.
His accolades are great.
Sorry, go on, my Chris. Yeah. I also ask people to consider, and I'll move along very quickly now, both consider the amount of carbohydrates, okay, and fats. Okay, you're laughing again. Oh, please, my Empress, don't say so as well.
I'm from Ghana, so a lot of our diet is yam, potatoes, spinach. There's a lot of carbohydrates, rice. I don't think we're really big on pasta. I think that's more an Italian thing and other nations, but that is a lot of our diet. But it is a lot of fish and spinach and a lot of vegetables. So I don't know if people have seen the plate of what you're supposed to eat.
I have.
The meat, the carbohydrates, the fruit, and it just tells you how much you're supposed, and it's supposed to be like a handful, so the size of your hand,
that's
of
right,
the food that you're supposed to eat. But I think and this is not backtracking what you're saying, but it is very hard to stop eating a certain type of food when you're so accustomed to it.
Mhm.
And that's what you've grown on, that's what you've been cooking, you have at parties, you know, to change that kind of food is very hard for certain people. But I do believe everything in moderation is good. And I do believe in terms of salt, if you put stock in your food, then you're not going to necessarily need salt, are you? Because that has all the salt and the flavorings it needs in the food. But there's nothing wrong with carbohydrates, but I know some people who stop having carbohydrates get a bit of a headache. So that's what I'm saying. If you are going to give up carbohydrates, again, reduce it in slow doses.
Thank you. And you made my point for me.
Yeah.
You recognize that the quantum currently in many of our cuisine is excessive. Yeah, it is excessive. It's become part of our cuisine. So it's a difficult habit to shake. I recognize that, okay? That's why I always say, please, this gradual reduction, be thoughtful what's going into your body, carbohydrates and fat, the frying of our food, the absorption of fat. Yeah, you're smiling again, you know? I want people...
Because you're making me hungry as well at the same time. You're making me hungry. So it's just, I'm thinking a bit of rice and peas, roti, potatoes, some callaloo, some spinach. I could think of a whole load of things I could eat today.
There you go. But the frying of, I've seen the family last night, and they fried plantain.
Love that.
Yes, it looked nice. I tell you, it was nice. I know when she finished frying the plantain, you know, it had maybe, she fried it in maybe 3 or 4 inches of oil. By the time she finished frying the plantain, the oil had gone down to less than an inch. In other words, the plantain had absorbed the oil. Yeah, it had absorbed the oil. So the plantain looked nice. And I put a little bit in my mouth. It tastes nice. But I now, because I reduced the amount of these things in my diet, the oil was very apparent in my mouth. You're laughing, in my mouth. I couldn't defend them by spitting it out. So I swallowed it one mouthful, but no more than that.
God, I can eat a whole plantain by myself.
I know.
I had someone, when I went to Dorset, we made plantains. We had about 6 of them and I cooked them. But I don't feel like, it depends on as well, shallow frying and deep frying. I think you have to distinguish that. And I know a lot of people have turned to air fryers now as well to get rid of the amount of oil that they put in their food. So maybe people investing in more air fryers, maybe an alternative for people who like.
But my empress, what you again is making my point for me. Our diet is killing us. Yeah, we see these women and men with these bloated sides, bloated bottoms. Yeah, the bloated chests. You know, it's bloated arms, these forearms. You see it? Yeah, it's killing us. It's killing us. Yeah. Therefore, at some point, we have to react. You know, if you're in a fast car heading towards a brick wall, at some point you have to react. That's how serious it is, because it's debilitating. It's causing our community to become totally, you know, incapacitated in some family groupings. Okay? So we have to respond at some point. That's why I spend these few minutes with these health messages. Because starch is another one, of course. Okay. But of course, the whole purpose of these messages is to encourage our listeners and our viewers to eat more fruits and vegetables, raw fruits and vegetables. Yeah, to encourage you. Yeah, before you start the day, let what goes into your mouth be untainted with chemicals. Is my recommendation. Yeah, you're smiling again. Yeah, yeah. Have an apple or fruit. Yeah. Eat a cucumber in some cases. Yeah. Eat something raw. Yeah. Raw foods, raw vegetables. Yeah. Yes, you might want to light steam it. Okay. But those vegetables with just full of carbohydrate, keep them in proportion. Okay. Green vegetables are our lifeblood. That's where we can produce blood from green vegetables. Yeah, we've got to eat that in much greater quantities. Yeah, more fruits and vegetables. Of course, adequate amounts of water. Yeah, Again, if you're not sure, please speak to your GP, speak to your nutritionist, okay? We had a nutritional pharmacist, Elijah Timop here, okay? And he reminded us we must drink at least 2 to 3 liters of water per day, okay? Depending upon your body mass, yeah? Again, speak to professionals and ensure that you do that. I have my water here, my Empress, I have my water here, okay? Really vitally important, adequate amount of water, more green vegetables, increased amount of fruit. Of course, to top all this, it's incredibly important that we exercise every day, meaningful exercise. My Empress, have you been able to exercise this morning? I'm only asking. You exercise, my Empress.
I literally woke up from my bed. And
No, don't give too much away now.
I didn't do any. I did enough exercise in Dorset. For those who went to Dorset with me, I did enough walking in Dorset. I think I've made up for it for 4 days.
Look, I have my weights. Look here, my Empress. I have my weights here.
You remind me of Mr. Motivator on ITV.
Oh, yes, I'm the motivator. Okay, right? You say, yep, I've got it. And I spent a good 35 minutes this morning going both arms, my legs, doing ups and downs, trotting, just so I can raise my heart. And yes, I'm a bit sweaty now.
I'm
so alive. What?
I said,
so alive.
The motivator.
Oh, that's right. Yeah. Because why? I want to live a long, healthy life. Full stop. Why would I want, forgive me, why would anyone want otherwise? So if it means I've got to significantly reduce the amount of salt in my diet, I'll do it. Significantly reduce the amount of sugar in my diet, I will do it. Reduce the amount of fat I consume, I absolutely will do it. Moderate the amount of carbohydrate I'm consuming, which accumulate around my organs, absolutely I'll do it. Yeah. Why would I not do it? It doesn't make, forgive me, my Empress, any sense not to do what is necessary to promote a long, healthy lifestyle. Yes, we form habits as children, but we're adults. We can modify those habits. So if there are better habits, more fruits and raw vegetables where possible, lightly steamed if you must, yeah? Moderate those other parts of our cuisine. Just moderate it, okay? And if in doubt, please, don't take my word for it, please go to your doctor, speak to a nutritionist, okay? They're the ones who give you the authoritative advice. I said earlier, I'm but an elected official. I see the figures, the public health figures, and the impact our actions have on our health, and the demand, therefore, we give and place upon, in Britain, the National Health Service. And those countries where you don't have national health services, you definitely want to stay healthy, yeah? Because health can be very expensive. I'm very, very well aware, yeah? So it's your choice. It is your choice, yeah? Is that fair, my Empress?
100%. And I was going to say, if people don't really like raw vegetables, eating them, or raw fruit sometimes, make it into a smoothie, add some almond milk, water, milk, some peanut butter. I know my friend does this, yogurt, and they make it into smoothies and they drink that in the morning. And that could be a boost of energy for you as well.
I think you're 100% correct. I could have said it better myself. And that's why you're here, to give that, to give that some additional nuance to what I'm saying. But of course, you're relating actual experience, because trust me, I was in the same position you were some years ago in terms of my overall taking care of myself. I absolutely was, yeah. So I'm no different. But I've seen, because of my public role, I've come across far too many people, far too many families who are ailing, who are simply ailing, okay? And these ailments, the many ailments that they're suffering from, are avoidable. So it's a choice, yeah? It's not simply our cuisine, it is a choice. We've got to simply decide what is in our personal, indeed family's best interest. Okay, there you are. So those of you who like to give children these bags of sweets, I want you to consider, she's smiling again, I want you to consider the long-term impact it has on your families.
Dry mangoes, dry pineapples, walnuts, peanuts.
Yeah, there you go. There you go. There you go. Right. So I'm going to keep so often we may have this dialogue, you know, my influence, and talk about how you're evolving, because watching you and hearing your evolution towards a really healthy diet that's appropriate for your physiology, okay, will encourage others to do the same.
No, I've got a young son, and he's been quite ill a lot in the last couple of months, and even before COVID. So we've had to change his diet, his whole. Well, I've had to change my diet as well because I've had my own health issues, and a lot of people around me. So I think we always definitely sending each other information about our health because we're very conscious. We are an ethnic minority, so I think we have to. And I think doing it together with someone is the best encouragement, as well as obviously with yourself. But like I said, you know, like we're a community, we need to do things together. So maybe, I know there's a lot of, in Southwark, especially in Burgess Park, there's like a personal trainer that does like monthly or weekly fitness regimes and boot camps. So if anybody's interested in that, he would be a great guy to go visit as well, if you want to change your health.
So of course, it's important to note for the audience, when you say Southwark, that's Southwark is a part of London.
Okay. Yeah, sorry, Southwark. Yeah, sorry, Southwark, the part of London. Southwark, the borough. Sorry.
It's always important, but the real message is that in most parts of Britain, there's opportunities for you to have a communal health exercise sessions. Okay, you just got to look for it, and it's always available. And if in doubt, I am contactable, and I'll give out the number. I'll give out the number now. Those who just simply want that advice, and I can try and find it for you. The number to call, it's 0208 133 5616. That's the number to call, and I hope that it is useful. Okay. If I may, just a quick reference to last week's program. What was your impression of our guest last week?
I love them. I love Sister Marlene. I love Sister Cremelda. I think it was quite mind-blowing to know that these things are actually happening. There's not enough awareness in regards to Black breast cancer. The fact that a country, obviously I don't know Sierra Leone very well. I have friends from there, but I don't know the country very well. That you only have one machine, one oncologist nurse, is mind-blowing, you know, for such a vast population. That's all they have, and children and young girls as well as 16, 13 are dying from breast cancer. You know, they're still retreating back to the old ways of, you know, seeking someone in within the community to help with health. And we know that's not the way to do things, but you know, again, it's fear, it's a stigma, and we
just one moment there, my impressed. It's a sound still not coming through. Okay. Oh dear.
Yeah, not too bad, but give us 7% more volume.
Okay, 7%.
Thank you.
Yeah, give us 7% more. Yeah.
Thank you. I appreciate you.
Yeah. Okay, I give her 7% more. There you are, ma'am. First, you have 7% more.
Okay. So I think it was definitely mind-blowing. I have definitely made awareness of it with my friends' Facebook, because I think it's really important. Because we want more of our people to survive through these things and tell their stories so other people can be aware of it. And I think it's a great opportunity. This platform's a great opportunity for us to be aware of these things. So I think they're amazing women who are doing amazing jobs in their field. And, you know, Cremelda, keep doing what you're doing. If you're out there listening, just keep doing what you're doing. You're inspiration to us all.
I must say, she almost brought tears to my eyes. We brought tears to her eyes, but I have to tell you, great women, great human beings such as that need to be honored, you know, absolutely, quite a remarkable woman. But I have to tell you, right, my friend, Dr. Marlene, I have to tell you, she can come on any time because she's such a wonderful mind, you know, a real stalwart in the community, totally dedicated to the community's upliftment.
100%.
Sister Marlene, Dr. Marlene, indeed. If you're listening,
Dr. Marlene.
yes, respect to you always. Respect to you. Respect to you always. But it's I know it's tough. These are tough times for us all, you know. So I want to applaud them. I want to applaud them. And of course, we've had a series of programs which have sort of focused on health, and I realise that. But it's such a massive subject in our community, one of primary concern, and should be of primary concern, if I may say so, to us all. Why I've had this number of programs which focus on health, different aspects of health. And a program I've not yet actually completed is one on prostate cancer in men. Okay, I do need to address that, and I hope that in the coming week we need to talk about prostate cancer in men and how it has permeated our community. But nevertheless, our guest today is a man of true distinction, and of course, he's someone who's worked within the National Health Service for many years. Academically, very accomplished. Okay,
100%.
but has seen the National Health Service inside out. Okay, and he's a testament. He's a testament to not only someone to pursue academic excellence, but as someone who's remained grounded. Mm-hmm. Someone who's an example of someone who's been able to navigate a bureaucracy, okay, the largest employer in Europe, and second, I believe, largest employer in the world. That is the British National Health Service. Okay. So his role as Regional Director for Public Health England and the Public Health Director for London, okay, gives him a unique perspective on health across the nation, but he has a particular interest, of course, in health in the Black and other ethnic minority communities. Okay. He'll be joining us shortly, Professor Kevin Fenton. Okay. And it'd be most interesting to engage with him on his experience in working for the National Health Service. Because we have many excellent members of the community who've excelled within the National Health Service and have faced significant adversity, mind you, but against all the odds, continue to strive and succeed. And he's an example for our children, young people who are either entering into medicine or nursing or one of the clinical allied professions, such as pharmacists, yeah, ophthalmology, dentistry, okay? It's an example that despite the extreme adversity, you can succeed. In fact, I think you agree, my interest, failure often is not an option. You've just got to take all the resistance and just power on. Yeah? Okay. Because you and I have great ambition for our children, huh?
Of course we do. I've got loads of ambition for my child. He's not ready. He's not ready. But what I've got for him. But yeah.
Yeah, I know. I just love your smile when you start speaking about your child.
Oh, I love my little. I'm not going to say his name on air, but yeah, I do. I love my son. He's a mini me, but a bit more calmer, so it's good. Yeah. But he's more interested in STEM, where I'm interested in the community. So we'll see.
So you've got to explain what STEM.
Oh, sorry. STEM is science, technology, engineering, and maths. So my son is very interested in that area.
Okay.
So, yes.
Well, that's
making his mum very proud.
Is there a specific one of those STEM subjects he's interested in?
Computing. He's always
okay.
He's very good at engineering and computing, putting things together, working how things work together. So yeah, he's and he's going to start secondary school next year. So
Wonderful.
it goes well for him. So
Let's keep praying and give him as much positive energy
yes,
that he succeeds, he navigates through secondary school, gets his GCSEs, gets his A levels, and you and I can aspire that he goes to university. You know?
Yes.
Yes. Oh yeah, indeed.
God willing, he will be going to university. But I told him if he doesn't, everyone has to take their own path.
Absolutely.
And, do what they need to do. University is not for everyone. Not that I'm saying you shouldn't, but I'm just saying it's not for everybody. Everyone can make their own choices and still be successful, no matter what kind of path they take. So, yeah.
Thank you. You're absolutely right. Now then, I believe our guest may well have arrived. Just double checking.
I can see him.
Oh,
with his
there you
lovely
are.
Glasses. We're both the glasses crew today.
Good morning, everybody. Good morning.
Good morning, Kevin. Can I call you Professor Fenton or just Kevin?
Well, you can call me Kevin, and can I call you Martin, or shall I call you Councillor Seaton?
Will do. Martin will do.
Martin's fine. How are you doing, my friend? It's been a while.
It's been a while. It's so good. You're looking young, if I may think.
I was going to say that as well. I said he looks much better on video than he does in his picture on Wikipedia.
Oh yes, definitely.
I love the moustache, loving it.
Thank you very much.
And Kevin actually introduced you to one of my co-presenters.
Yes.
There you go.
Hi, Kevin. Nice to meet you.
Really good to meet you, Abina. Is that the right pronunciation?
You can say it that way, Kevin. I'm very easygoing. I'm not.
No. But which way do you prefer me to say it? Do you have?
Most people say it. Oh God, Martin says Abina. My friends say Abina, but I'm very easygoing. I'm not really.
Okay. All right. Yeah.
All right. Oh gosh, there we go. Don't start, Kevin, huh?
It's going to be one of those shows today, I can tell.
Okay, but the subject matter is incredibly important. Okay? I'm very conscious that this is a relatively early morning show. Okay, so I'm not expecting people to call in. It's quite clear from the feedback I'm receiving what is really appreciated is that shows are information rich, okay, and there's opportunities for listeners to review the show either via YouTube or Facebook, where we're recording. Okay, and if you are reviewing the show via YouTube or Facebook, I'll simply ask you please to give us a like. There you are, those thumbs up. There you are, the thumbs up. Or indeed subscribe, and that gives us an affirmation that you are paying attention, you want to be made aware of future shows and their subject matters. This show, of course, will feature the most common theme I've had throughout this year, and that is the health in the Black and other ethnic minority communities. It looms large because the impact of our health has a direct impact on our economic viability as a community. It's a direct impact on our positions in public life. Okay? It has a direct impact on our spiritual well-being. And indeed, it has a direct impact upon how our children will view themselves in our society. It is a profound subject, one that we must continue to take seriously. For the purpose of these shows is yes to entertain, we've had a bit of entertainment just now, but to inform, okay, and to motivate people to take action. Okay? And Kevin, we're grateful. This is the second time you've been here, and I know it's been a few years. We've had that event in between, okay, and I need to start off with that event with COVID-19. I need to start off with that. I know last time you were here, there was a big debate as to whether or not you should take the vaccine or not. Was it safe for us? Would it cause infertility? Is there a chip in it and that we'll all be tracked and so on and so on and so on? It was quite remarkable discussions we used to have, quite remarkable discussions. Okay? And there was some historical correlations to why those discussions were necessary and so on. But I don't want to go back to the past. I want to look to the future. and you hold a strategic position in the NHS. And before I go to the substantive question, I might just ask you just to explain your role in the NHS. I quote you're the regional director for Public Health England for London. Just what does that role mean in terms of your role, in terms of responsibilities that you take on? What does it mean to be the Public Health Director for London?
Okay, so good morning, Martin. Good morning, Abina. It's so good to be here with you again, and thank you for inviting me back on the show. As you know, I love community radio. I love being able to speak directly to Londoners. And as I've learned through the pandemic, access to both senior officials in the city, but people working to improve the lives of Londoners is an important part of our roles and responsibilities. So I take these opportunities really seriously because it is in the conversations, it's in the debates, it's in the reflection and challenge that I get a sense of what really matters to people and what more I can do to help. So you asked me about my job. I'm the public health director for the city. Some cities, for example, in New York may have a health commissioner. Others for Berlin, Paris also have public health or chief public health physicians for their cities. And essentially, I am the most senior public health practitioner in the city. I report to the Mayor of London, Sadiq Khan. I'm his statutory health advisor. I also report to the head of the NHS in London as his regional public health director. And finally, my salary is paid for by the Department of Health and Social Care because I'm one of the directors of the Department of Health and Social Care, and I'm the director of the London office. So my job brings together a group of public health professionals that provide support to the mayor, to the NHS, and provides feedback to national government on the work, that fantastic work we're doing in the city, but also helps to implement government policy.
If I may, just to clarify, and just for the audience, I suppose, distinction between public health, what happens in, say, a hospital, such as one of my local hospitals is King's College, for example, or indeed the clinical commissioning group here. In my case, it's the Southeast London clinical group. What's the distinction between these bodies, public health, hospitals, and the clinical commissioning groups?
So remember, public health is a clinical specialty, it's a subspecialty of medicine, right? So it could be cardiology, you could be neurology, you could be a GP. I chose to be a public health physician. But public health, improving the health of the population and tackling health inequalities is everybody's business. And that's why I report to so many different agencies and I work with different agencies, because the NHS not only provides high quality clinical care, but they are in the business also of supporting prevention. And they are also in the business of improving the health of the local populations. And the NHS has also been through a big reorganization where they now create different levels within the region. So you have the regional office, which I work in. You have 5 sub-regional offices, which are called the integrated care systems. And these are going to be the major new drivers of how health and the NHS is going to operate in the future. And we have 5 of them in London. And Martin, you, as you know, work in the Southeast London ICS, Integrated Care System. And then within each care system, you have what are called place-based boards, where each borough within will also have a focus on improving health and tackling inequalities. And then within each borough, you have primary care networks, which are groups of GPs working together to deliver services. And at all of those layers, Martin, whether you're at the region, ICS, at the sub-region, at the borough level, or in the primary care, every level is focused on prevention. Every level is asking about public health, because the work that we do as public health physicians and practitioners helps the NHS to do a better job of commissioning its services, of tackling any inequalities, and of understanding its data so that it can do better by its community. So public health is fully integrated in every level of the NHS. I hope that helps, both to explain the NHS, but what we do as public health people as well.
I completely understand. Thank you. And just help the audience to understand.
Gave me a big understanding as well.
I realise feedback. It's interesting. You know, people living under all their lives have got no idea how the NHS is functioned. Okay,
that's right.
The big elephant in the room, that COVID experience. So my question here is that, have you been through the experience? What are the lessons learned?
That's a great question. And in fact, it's one of the things that I'm asked to speak on most. You know, Martin, as you know, I do a lot of public speaking and lecturing and talks because, again, in the spirit of engaging, and people ask about the lessons, and I'm trying to move the discussion on from not only lessons, but to talk about what legacies should arise from the pandemic. And the legacies for me are more important because the legacies demonstrate that there has been true learning that has taken place and that the behaviors have changed, and therefore the outcomes that we're working on are now more likely to be achieved. You and I know, I know many of us have children, nephews, nieces. You can learn lessons, but you go back and you do the same old, right? So it's not a matter only of learning the lessons, but truly changing the behaviors. So you'll hear me speak about 5 things, and I'll tell you them really quickly. The first is the power of partnerships. We worked together in the pandemic in ways that we have never worked together between the NHS, local government, local communities. Abina, you remember all of the town hall events where we had, past people coming together to work together, and we had difficult conversations with the community. But by being in partnership, that meant that we were all focused on getting through the pandemic and saving the lives of Londoners. And we learned new ways of trusting each other, local government, NHS, national government, and working together. Number 2, the power of community. Martin, we could not have got through the last 2 years without communities taking control, being empowered, asking questions, challenging the government response and saying, actually, we need more money, we need more support, we need information in our own languages. All of those things where the community said, this is not good enough and we need to strengthen our approach. And that was certainly another lesson. And a legacy of that is that in the work that I do with the mayor, with the NHS, with all the public health agencies in London and local government, we are looking at locking in the sort of community infrastructure we have, right? So community, COVID ambassadors, health champions, strong work with our community organizations. The third thing is data. We learned a lot about data. And Martin, there's a point where I could tell almost where every COVID infection was occurring in the city. And I could tell you what level of vaccination that borough had. I could also tell you about where the vaccine centers are, and we could really provide very tailored care to that individual or to that community. We should have that data for diabetes. We should have that data for hypertension. We should have that data for cancer so that we can do a better job of really targeting our efforts now and making sure that we do better by our communities. And that has to be a legacy, because all of the things that we were told we couldn't do before when it came to data, sharing data, making it publicly available, making it transparent. So if you live in Lewisham and you want to know, where are the best places to get to see a GP and how are the GPs performing, you should be able to go online and have a look at that and to make decisions about your health based upon data. And there are a couple of other lessons and legacies, which is around the ways in which we do research. Martin, you'll remember at the beginning, government asked me to investigate the impact of COVID on inequalities. And the work that I did was the first in the country to say, Black communities are being disproportionately affected, and we need to change the way we are responding, including the way we do research. And a lot of that has taken place over the last 2 years. I'm really pleased about that. And then finally, just the leadership that we need. That is leadership which really is open to tackling the systemic issues which hold communities back. And the COVID experience, the George Floyd murder, Black Lives Matter, all brought not only racial consciousness to the COVID response, but the focus on health inequalities, which I've never seen in the 30 years I've been practicing public health. And so when we talk about a lesson, one of the lessons from the COVID pandemic is what we now know about what drives inequalities, and an openness to talk about systemic and structural racism, discrimination, and how that holds communities back, and ultimately how it kills our community. Because when people don't trust health services, and when health services are not geared towards their diverse communities, everybody loses. And so that's another lesson from the pandemic. And a key legacy is that we're working now across the city to ensure every NHS organization, every organization in care stands up and declares themselves as being anti-racist. And we have a set of commitments that we're asking organizations to sign up to, because we cannot come out of the COVID experience and go back to business as usual, because business as usual didn't work.
If I may then, and I'm then going to let Professor Abner come in immediately after. I'm a mature man now. I've reached a stage where I've seen cycles. I've seen quite a few cycles. And I acknowledge that a anti-racist position within the NHS and embedded in the documents is a good step forward. But I had the same conversation 10 years ago, similar conversation 20 years ago. And in my case, similar conversation 30 and indeed 40 years ago. Okay. I recall in the early 80s, very similar dialogue occurring. There seems to be a missing component here. And if I may suggest, and maybe, and this may or may not resonate with some of our listeners, and this one get it right. You've discussed structural racism is a problem, okay, but that's simply a euphemism for those who are either directly delivering healthcare, doctors, nurses, or administering healthcare, okay, are acting out biases. That's a very nice word to use, huh? In the practice of healthcare, that delivery. What you haven't included in what you've described, and I've been looking and I've checked with the various agencies, is what are you doing to work with consultants, nurses, who hold views that are in contradiction to the 2010 Equalities Act? How are you tackling it? Because it's at the point of delivery, that point at which you're experiencing healthcare, that many of the community are experiencing differential treatment. So how are you supporting those who hold views and attack those views in contradiction of the 2010 Equalities Act?
Yeah, well, I'm glad you raised that, because that brings us into a really good discussion about what being anti-racist means and what an anti-racism approach within organizations means. Because, you know, you can have declarations that you're against racism, and my goodness, you know, you hear it all the time, from the Football Association to the police to the Cricket Association, etc. But anti-racism is a structured program in which you look at every aspect of how your organization works, and you not only confirm that you're going to change your behaviors in order to address systemic racism, but you're going to do so in a way that is accountable and that demonstrates an impact over time. So in the approach that we are discussing and developing for London, the 5 elements of our anti-racism approach include: number 1, executive leadership of the organization, of middle management, of every member, a leader, and every staff member, of understanding what being anti-racist is, because it takes it from a passive position where other people do it to an expectation that everybody in the organization now is going to focus on these issues of systemic and structural racism. It includes how you look at your HR processes and how you take care of your Black, Asian, and minority staff through equality, diversity, and inclusion, training and initiatives, looking at your HR data, questioning why is it that all of the people of color seem to occupy lower level jobs and the more senior executives are white, and having plans in place to both change the distribution and to support our staff. Because you and I know it's not just getting into the senior roles as a senior Black person, but you have to be supported to operate effectively at that level as well. And too many stories of people like me who are senior, and then all of a sudden you find you have absolutely no support to deal with the things that you have to deal with. So that's the second thing in being anti-racist. The third thing we're asking organizations to do is to look at their health programs, which are specifically targeting inequalities, and to work with communities to make them culturally competent. And this is what we did in COVID, where initially, remember the first 2 months of COVID, you and I had this conversation, all of the ads on COVID had white people on there. None of them were in any other language apart from English. All of the ads were either online or in the broadsheets, not working with minority, the voice, the nation, none of in the first few months. And I called that out and I said, listen, you cannot be giving information on this pandemic through such limited channels. So everything we do as an anti-racist organization and the programs we develop must be through that. And then, Martin, there are 2 other things which we're also asking every London health and care organization to do. The fourth is being an anchor institution. So, the NHS has an amazing opportunity. They employ so many people. They commission from businesses all over the country. We need now to harness the NHS, which is often the biggest employer in communities, to think about how they're employing local residents. What career pathways are you providing to your diverse communities? We're talking about King's College recently, a huge employer in South London, in Southwark and Lambeth. What is your pathway for encouraging young Black students to come in to think about a career in health? And what sort of accelerator programs do you have for local residents coming in? How do you provide the London living wage to all staff? So especially the staff which are more likely to be Black, Asian, and minority and doing a lot of the support work in systems, are paid better so that they can withstand some of the challenges that they have. How do you support Black-owned businesses and women-owned businesses as you commission? That is what anti-racist organizations do and can do. And then the final thing we're asking as being anti-racist is for organizations to really think about how they're engaging with their local communities. Too often, I hear NHS organizations say, the relationship with the X community has broken down and we're not sure how to improve it. That can't be the case in the 21st century. If you don't know how to do it, get a consultant in. If you don't know how to do it, my God, work with your local authority, right? Who already know and have great relationships with their local communities. We can and we must do better, and we cannot stand behind any excuse where we're not bringing local communities in to be active players in decisions about their own healthcare, who's delivering it, and the quality of the services that they're getting. And we must do that. So that's the 5 areas in which anti-racism takes it, I think, Martin, from what you described 40, 30, 20 years ago, which may just have been, platitudes. Yes, we're going to change and this, we need to do better because there's been another inquiry. And what I'm doing now and what we're doing as London leaders is breaking it down and saying, here's the playbook. And if this is the playbook and you declare yourself as an anti-racist organization, we can come in and see how you're performing against it. And we can ask the staff how they feel. We can ask local communities about how they trust. And we can ask everybody in that organization about whether they've truly embodied the spirit of anti-racism. You know, in no place would you accept gender inequality. In no place are you going to accept differences because of your sexual orientation. Why, in any place or form, should we accept discrimination based on the color of our skin? No, we don't have to wait until we're called institutionally racist. We can do things now, and the anti-racism platform is going to be an important part of having those discussions in our health and care system.
Thank you very much. And that's a really good detailed answer, but it's about, of course, raising confidence in our services. Absolutely. I wonder if, I don't know, you want to ask a question this point.
Yeah, I was very interested in the fact that you said, you know, you're trying to find pathways for children, for the community to get into the NHS, you know, trying to create that self-awareness within the NHS, because I know a lot of I'm a family support worker in 2 schools, and a lot of the parents say, you know, a lot of the services they had before, like health workers coming into the community and supporting, coming into, that doesn't really happen anymore. And I know due to COVID, a lot of the things were cut back, but that's all I ever hear is there's cutbacks, or this person's not available, or they're overstretched, so they can't support, you know, parents who have just had babies or come in to do dental care with the children. Those have kind of stopped in our communities. And, you know, a lot of the people that come in the communities are not aware that some parents have language barriers, you know, they don't have the communication to deal with certain families. And I think, like you said, that's something that needs to change. But how could we support schools more with those kind of situations?
And, you know, that's such a great question, because it is about how do we navigate this very difficult time in our society where, you know, by all accounts, you know, things are going to be very hard economically. Both candidates for the leadership of the Conservative Party are saying that there's no new money for the NHS. And so we're going to have to use the resources that we have wisely while doing the things that we need to do, and that we know are the right things, which is why I come back to this issue, not just of lessons, but of legacies, because it's going to be too easy for people to say, actually, there's no money, so we can't do the things that you want us to do on tackling, you know, racism or being an anchor institution. And that's not the case. The NHS still receives billions of pounds here in London and across the country, and it's about how we use those resources. But to your question, I think this is where community action and activism continues to be important. The reason why the NHS has changed is that they want to become much closer to communities, and they want to integrate the insights and the assets from local authorities to help to do a much better job of providing health and care to communities. So the local authorities commission health services, but local authorities also build new, warm, safer homes. They improve the lives of communities. They provide job opportunities. All of those have an impact on health. And the NHS can provide better quality care, pathways for employment, and think about how, by working with local authorities, they can either pool resources, share resources, or local authorities can say, actually, our communities are now saying that this is far more important to them, and we need you to use the available money to reprioritize so that some of these issues can be taken care of. And Abina, you raise the issue, which is a good one, about maternal care, because in the last month or two, there have been reports which have come out which are saying in the 21st century, if you're a Black woman going through a pregnancy in this country, you're far more likely to have bad outcomes and to unfortunately die. And when you look at the reasons why you're seeing this, many of the same structural issues that we see and we've been speaking about are on the maternity pathway. So women aren't getting the information they need when they're in hospital. They're not getting the care they need, either because they don't speak the language or because of the biases that providers have. And then the aftercare isn't there either, and therefore you have worse outcomes. So if this is a priority for our local authorities and local people, the new systems should be saying, we need to sort this. And that's exactly what we're doing in London now, where there are a few things that we're looking at. And I've said, we need to look at how we care for people with sickle cell disease. Because it is one thing that our Black communities have. We have many health issues, but it is a uniquely Black issue. And if we cannot do better by that, that means there's a problem with the system that is not allowing us to look at the quality of care for people with sickle cell disease. The second thing is looking at maternal pathway. We really want to work together because we know that that's an area where we have a lot of inequalities. And then the third area is around mental health. And, Black men are far more likely to be sectioned under the mental health order. They're less likely to benefit from some of the early preventive interventions. So counseling, good medical care, good outpatient care. So we have a lot of Black men who are sanctioned. So we want to look at that and to say, actually, how can we do that better? So there are a few areas now that we're working across the city to say, as part of this work on anti-racism, here are some of the things that we want to test to see if by adopting this approach, we can also see real improvements in some of these areas.
I was going to ask as well, for me personally, I'm in the community, but I've never seen enough awareness on sickle cell myself.
Mm-hmm.
Mental health has been a big push in schools because, we've got Place to Be, Young Minds, we've got all those kind of organizations. But why is there a lack of sickle cell? Because I know it affects the Black community. I've worked with a family whose daughter has sickle cell.
Mm-hmm.
I don't feel there's enough push. There's enough push for cancer, mental health. But sickle cell seems to be one of those things that is just there, but it's not. I remember a young boy who died of it, and his mother and him campaigned for it a lot. I can't remember the name of the family, but with sickle cell, there isn't enough within our Black community about it. And I don't know, and obviously mental health is more focused on the young because of COVID. But in terms of our Black community, apart from Black River Counselling, which I know is based in Southwark, I don't know anyone else that obviously feeds into the Black community in regards to mental health.
Yeah, well, there's so many community initiatives going on, where we have Black Thrive, which is a pan-London program that really focuses on the mental health and well-being of Black people, and they do amazing work. There's Good Thinking, which is a digital platform, so you can just go online, talk about, go to goodthinking.co.uk, and you have online tools which we know work really well that can help you with everything from anxiety, depression, if you're not sleeping, and how to become more resilient. So there's lots of community organizations doing good work. At the core of it, though, Abina, is being more systematic in how we approach this issue of Black health, empowering our communities so our communities understand the power of their own voice and know how to channel it. And Martin, as a counselor, this is so important, right? That you're representing the people, and the people need to understand, actually, if we're not happy with our services, how do we get that translated into the NHS, and how do we work with the local authority and the NHS to improve services? And then finally, in all of this, we need to ensure that we keep a sort of, we have to be agile, because new things come up all the time. We've come out of COVID. I'm now dealing with monkeypox. We have polio, appearing in the water system in London. So we're going to have to be looking at those. And it's important that we continue to have these conversations about health with all our communities, including the Black community. So we're much more empowered and engaged. This is not the time for any of us, especially coming out of the pandemic, to sit back, relax, and think we have nothing else to do with health, and we can get on with things. Martin, you started by saying health is the most powerful asset we have. It is. And yesterday I had to say goodbye. I went to a funeral of a dear colleague who passed away, unfortunately. And she's just a couple of years older than me. And it really, on many levels, it hit me really hard, because this is somebody I've known for nearly 30 years. And it reminded me of the preciousness of the gift of life. And also, no matter how powerful you are, when you lose your health, how that can create so much difficulty and challenge. And you really realize, don't take this for granted, be engaged, be informed, you make sure that you take steps to improve your own health and the health of your community as well.
And you don't realize that, of course, you are the reason why the first 15, possibly 20 minutes of each of my programs, I discuss health.
Oh.
The reason why.
He does. Right, he does.
I'm so glad to hear that.
I'd follow your lead is absolutely right. And your ability to communicate the message was outstanding. And I could not, because you were in Suffolk, of course, I could not but follow that lead here in this public platform. I'm privileged to have this public platform to continue to announce these essential health messages that we as a community must respond to. Okay. And if I may just go back to what you said earlier on, and I'm just conscious of time, so we want to make sure we're getting all the other key questions in as well. But I do want to keep at this point, because of course, ultimately, the relationship between the community and NHS is one about confidence and trust.
Yes.
Yeah. That's the issue, confidence and trust. Okay. You have confidence in them that they are professionally trained and competent. Trust that they will apply their training appropriately. Oh, good morning. Hold on a second. Have I got a call on the line?
Yes.
I haven't quite opened the lines, but I'll take the call anyway.
I'm Councillor Sitting to Marcia. I wanted to ask him about Rastafari and mental health.
Oh, Sister Marcia, good morning to you. You can ask your question. Go ahead and ask your question.
Right. In regards to Rastafari in the community, we are more sectioned than anyone else because we are saying Jah instead of saying Jesus. So how would Professor Fenton deal with that? Because I'm sure I wrote to him in regards to some commissioning to look into that. So is he tackling that in the community, Rastafari and mental health?
That's a fair question.
That's a really good question. And that's one of the reasons why we want to focus on mental health outcomes for Black men, especially, who, as I mentioned, are sectioned at a much higher rate than all other men. And we're not seeing the appropriate early mental health care being given to Black men and women. And that's one of the things that we really want to look at in the pathway. And I know many of those who are being sectioned, as you say, may come from a Rastafarian background. So we really are looking at this. This is one of the things that we wanted to change. And it's one of the things that, if we intervene right, we can make it an early difference on this as well. So thank you. That is very much on our radar, and it's certainly something that we will look to work at, along with sickle cell disease and maternity health.
Looking forward to hear from you.
Okay, thank you.
Thank you.
Thank you, Sister Marcia, for that question. And if I may, as you know, Kevin, I'm an elected official, so I'm used to scrutinizing highly capable people like yourself. Time frame.
Yeah.
What community is interested in, and I note that if I go to the website managed by the Race and Health Observatory, and you are on that board, it's commissioning various pieces of research, which this is mental health, of course, is one. Back in April this year, I gather. What is not clear is when that report will be produced. And indeed a narrative outlined to the community, so we better understand the implications of the report and action that will follow.
Yeah.
Give us an example, because in fact, referring to the Race and Health Observatory and its commission of these reports, what is your expected time frame for both the report to be completed and a narrative to be explained to the community as to what actions you will follow?
Okay, so as you know, the Race and Health Observatory is its own organization. It was one of the legacies of the pandemic, and I'm one of the founding board members of it. We received monies initially from the NHS to do some specific work on ethnic inequalities because of the work that we had done in COVID. Reports are necessary, but they're not sufficient, Martin. And if I look at the amount of reports that drop in my inbox on a daily basis, it overwhelms you. And to be honest, many of them I just flip through, read the executive summary, and then you sort of move on. So it's not about only getting the report, but what we do with the report in terms of taking it to the health and wellbeing boards, having it conversations with local authorities and the NHS, challenging the commissioning and the annual plans for commissioning to say, how are your commissioning intentions going to change as a result of this finding, and how soon can we put it into the cycle? So the Race and Health Observatory and our outputs, we're committed to doing high quality research, getting reports out, disseminating it, and then working with local partners to say, it's now your job now to convert this report into action, because we're shining a light on where the differences are. And in fact, the work that I described on maternity, sickle cell, and mental health came out of the recent report from the Race and Health Observatory at the beginning of this year that said, here are the 10 areas where we're still having big differences in health outcomes for Black people in this country. And here's why. And so in NHS in London, we said, okay, we won't take on all 10 because we're doing lots of stuff. But here, there are going to be a few of them that we're working on this year, next, to really change. So that's how the process works. But let me tell you, a report does not change things. It's what happens when the report is published and how you get it into the system and hold the system to account for change. And that's why your role as a politician is so important, because you can do that through scrutiny.
Without a shadow of a doubt. I have a problem with this entire process, I have to say. You said, over the past 40 years or so that I've been in public life, there have been not 10 or 20 or 40 or 80 or even 160 reports. There have been thousands of reports on each of these subjects. Okay? And you're right. Clearly, that was a complete waste of money. I suppose the real problem I have with the entire system is that it's so passive. I'm surprised that the observatory has so little powers to impose or to give direction. But clearly, it is not acceptable that a health authority resists change. Simply not acceptable. Mm-hmm. And whilst you're right to some extent that the local politician can put some pressure on, but it's absolutely the responsibility of the board, the trust board, or the CCG board. That's where the pressure should come from. And what I note, Kevin, is that apart from your own board of the Race and Health Observatory, the boards are lamentably lack of diversity on those boards. As well as the senior leadership, clinical leadership, complete lack of diversity, particularly across London, and most certainly here in South East London.
Yeah.
What are you going to do about that? That's where the problem resides. Yes, I'm putting a great deal on your shoulders, but
yes, you are.
You are, and we're all leaders here, right? So you're a councillor in Southwark, being a year leader, we are all leaders, and while important to understand what happened 40 and 30 years ago, the reality is that we are the leaders of the system now. So if you think that the system is passive, then the question is, well, we're the leaders of this system and we are in charge of this passive system. So I say to my team, and you will hear me say this when I give my leadership discussions, there's nobody coming to save us but ourselves.
Right.
There is nobody coming to save us but ourselves. And we are the leaders that we've been waiting for.
Wow.
Right?
I can make a passion out of you to keep this up.
Are the leaders we have been waiting for. So when I talk about the work that we're doing to convert every hospital, every trust, every ICS system around an anti-racist agenda, which is much more proactive. And part of one of the pillars, remember I mentioned one of the pillars, which is about executive leadership on anti-racism, that includes in the sort of sub-bullets and objectives that you think about diversity inclusion, that you have an executive lead for inequalities, that you have a plan for tackling inequalities within your organization, and that you have a plan for tackling and supporting your BME staff. That's the sort of charter, and that's the sort of specificity now that we need. I'm no longer in the business of saying to people, oh, I wish you were anti-racist. No, no, no. Now I'm saying, here is the game plan on becoming anti-racist. Let me help you and give you the pathway, and we will work with you on that journey. And we will know which organizations are coming to us and say, oh, you know what, we can't do it, it's too busy, or those which say, and there are many who say, thank God that you're providing this clarity, because what we have now is a playbook, for want of a better phrase, is a guide that says, here are the things we need to have in place. Here's the behavior that we need to have in order to get that way. So, 40 years is important because we need to know our history, but it's what's happening today, and we are the ones that we've been waiting for.
I'm going to accept that as a response, and I think you're spot on. Of course, we are change makers.
But then I was going to say, because I know kids are great ways of being leaders as well, because when you go into a school and inform kids of certain situations that goes on in the community, they're very good informers to their parents who don't speak English, or who are supporting their parents, maybe young carers or whatever their role is in at home. So maybe we need to do more in our communities, in schools, and create, I know schools have other agendas going on, but creating that awareness about children's health needs to come in the schools, because if the parents are not getting it from the GPs, maybe we need to go into the schools and reiterate what's going on in our communities, because in certain boroughs, we have a high density of our people in the community. So the Black, Asian, Arab communities, they are in a lot of places within Southwark, or maybe Hackney, West London. So maybe going into schools or having a day where someone from the community of the NHS comes in and talks to a parent about, sickle cell is high at the moment, or we've got it's very predominant in our community. Do you know enough about this? Raising that kind of awareness maybe is something that we need to do.
Yeah. And you're right, Abina. And the solutions are never always going to come from government.
Yeah.
Yeah. And I won't say anything more because I don't speak on political matters. But if we truly are going to get out of this, we can't be waiting for government to provide all of the solutions. And what you've just said is another example where communities can take action, and communities can say, actually, here's a problem that we identify in our community. We'll go to the council, we'll speak to the director of public health and say, how can you help us to tackle this? They then work with the NHS and say, okay, here's a program that we can put together to help you. And Martin knows this. When I was in Southwark, that is exactly the sort of thing that I would do, that I'd listen to people on housing estates talking about their poor housing or their poor heating. I'd go out in community and meet with community groups in Southwark, and they'd give and ask for things that they need. And within the power that I had as the director of public health, or working with other people in the borough, then we tried to find solutions. And it may not happen overnight. And sometimes you need to be loud and you need to be, cause a bit of ruction, as we say, because this is not a time for us to be passive. There's too much going on now affecting the lives of our communities. And I think we need to ensure that we're clear and consistent in our asks, that we understand how the healthcare system works, that we work with our local political leaders, because they are your elected representatives and they are able to also champion your needs and check the NHS and the new systems that we have. And of course, work with your local director of public health. There are things that we can all do and communities can do as well. And I'd love to see more of that community activism and engagement and empowerment as we move forward. And I guess, Abina, the question for me back to you and to Martin is, what can we do together? What's holding our communities back from coming together and saying, actually, we now need to take care of ourselves. We need to be part of the solution too. What can we do? What can communities do, and what's holding communities back? That is a question that I would ask.
I think that's, again, a fair challenge, because I put this to the community every week. Taking responsibility. And I know there are some, they may call up today, you never know, who suggest that we should totally divorce ourselves from what might be considered to be a hostile NHS service. Okay. You know, I can quote here from the Race and Health Observatory. You say to my this side, we'll go right on that side. And what's more important is this figure here, 24% now. Let me just say this one more time. 24% of all deaths in England and Wales in 2019 were caused by cardiovascular disease in Black and minority groups. When we only constitute what, about I think about 4% of the national population. 24%. That's an epidemic of significant, almost biblical proportions, isn't it? Shouldn't that be a public health emergency, one that should be on everyone's tip of the tongue right now? Those figures are so frightening. Cardiovascular disease running at 24%. That is off the chart. Any organization that had that perform in the private sector at that performance level, you'd go out of business. You know, the board will be replaced.
And that's such a good example, because of all the things in that figure, and this is now a big priority for the NHS, because we realized with the pandemic, a lot of blood pressure control and cardiovascular disease control got hit hard because people weren't able to see their GPs and so forth. But Martin, you know, there are three things which we all can do when it comes to our cardiovascular health. Number one, know your numbers. So if I ask you and Abina and callers, when is the last time you had your blood pressure checked? Do you know what your numbers are? How many of you can be able to tell you your numbers? The second thing is, you can get your own blood pressure kit in Boots. It costs £15. It's one of the best investments that you can have in your own health. It's a digital blood pressure machine. You can spend £15 on one. You can get the one on bells and whistles and pay 60, 70, 80 pounds for it. But with a blood pressure machine, you know your blood pressure and you keep track on it, right? Second thing, know your numbers. The second, every house should have a blood pressure machine. Abina, I hope you have one in your home. Martin.
I had a blood pressure taken last week when I went to for my checkup. So I don't remember what it was, but I did have my blood pressure checked and it was fine. So I'm good. I'm all good. I'm still kicking, alive and kicking. So I know it's okay, but that's good to know, because I didn't know that cardiovascular affected us really badly like that.
It does. And then the other thing, of course, is that, you know, or if you're overweight, if you're not getting exercise, those are that's the third area about taking care of your physical health. Because if you're not, then that also drives up your blood pressure. And when your blood pressure is high and uncontrolled, people die from strokes, right? And how many of us in our community have lost family members way before their time? Way before their time because of strokes. My two best friends when I was growing up in Jamaica, who are now who would have been my age, one died at 49 from a stroke, driving his car to work, died from a stroke. And the second died at 51, found in her home because she hadn't gone to work, and people being at loss before their time because they weren't controlling their blood pressure. So this is real to me, Martin. When you give a figure like that at 24%, that's not some abstract statistical thing. These are people, these are friends, these are family members who we lose because we don't have a blood pressure machine in our home. We don't have our numbers, and we're not taking care of our health. So Martin, it comes back to your point. Yes, the health service must be doing better, but we all must be doing better too, right? We have to take responsibility because nobody's coming to save us but ourselves. And there are things that you can do every day. Eat better, even if it's tough. I know it's expensive. I'm changing the sort of meals I have now because I'm like, I have to, you have to rein it in, right? I go for my walks, I go to the gym, I look at my weight, I make sure my weight and my BMI is in the normal range, and I have my blood pressure machine. I have my blood pressure machine and I have a pulse oximeter in case I get COVID, so I can check my blood oxygen. These things don't cost a lot, but my goodness, they're good investments in your health.
So we need to, as a community, we need to prioritize our health rather than going out to get takeaways. We could get that could amount to a blood pressure machine, a gym membership, rather than getting. We need to just prioritize. Basically, is that what you're saying? And making sure that we're investing in the things that are going to save us rather than things that are going to kill us.
And Southwark is amazing. I mean, I don't know if you still have free swim and gym. But when I talk about this in other parts of the country, they're like, what? A borough is allowing people to use their services for free? I say, yeah. So, Southwark is reducing the barriers for people to become healthy. So the question is, what's stopping us from going that extra mile? So Martin, when you talk about that 25%, I want us to think about our auntie, our grandparents, our friends who we lose unnecessarily because we're not doing the basic things we should be doing.
Thank you, Kevin. And I
just wanted to ask, the 24%, is there an age range it's between? Because obviously I'm going to say what my age is, but what age group is it? Because I wouldn't say it was under 25s. Would you say it's the over 30s to like 50s? Or?
So in general, the older you are with high blood pressure, the older you are, is the more likely that you will develop high blood pressure. For Black and Asian people, we develop high blood pressure earlier than white people. And that's part of the problem, that we think, oh, I'm only 35, so I don't need to worry about it. That might be the case if you're a white person, because they tend to develop it at 50, 55. Too many of our Black people and our community develop it early. And the reason why we develop it early is that many times we eat too much salt in our food. I had ackee and saltfish for dinner last night. It was a bit too salty. Sorry, I have to keep it real, right? So people know that I'm not speaking about, our food is too salty, we're not getting enough exercise, and many of us struggle with unhealthy weight. And so therefore we get high blood pressure early. And because it is a silent disease, you don't know you have high blood pressure unless you're testing yourself and knowing your numbers. And then that's what happens. So people will have years of high blood pressure and not being diagnosed, and they're not going to the GP for checkups. And so therefore, when it's discovered, it's complicated, and they have kidney disease, they have heart disease, etc. So that's why we have what we have, Abina, and what I think we can do together. And if it's one thing from this morning's show, go out and get your own blood pressure machine, please. £15, I promise you, in Boots or your local community pharmacy.
And now you've said this, Kevin, I have mine here. It's in the other room. I won't get it immediately, but I'll demonstrate it every week henceforth. Thank you, Kevin. Demonstrate it's an invaluable tool, cheap but invaluable tool. It's not authoritative. Okay, you should still go to the doctor. Checkup, okay, on your blood pressure, but it's a good guide as to what might be happening.
Exactly.
I mean, that's really cautionary tone. But I will do this again. I've been inspired by you to do the same. I see we have a caller. Let's take this caller very quickly with number ending. I think it's 99. Is it 04104? I see we have a caller. Let's take this caller very quickly. Good morning, caller. I think it's 9104.
Good morning, Martin.
Good morning.
Can you hear me?
Yes, we
can.
Good morning.
Yes, hello, Martin. Good morning. Morning, Kevin. Good morning, Abina.
Morning.
Morning.
Kathy de Crescent.
Oh, yes. Hello, I
morning.
like that.
I'm ringing
Yeah, go ahead.
Okay.
If you could turn off the device in the background. Turn off the device in the background.
Sorry, I'm at home. I'm watching you on my laptop, and
just
there's
turn
a
off the
delay
volume.
in
Turn
what
off the
I'm
volume.
saying, so it's slightly weird.
Yeah, mute the volume.
So, I'm at home. Turn off what, Martin? Turn off?
Mute your volume, the audio.
Turn off the phone?
No, the mute.
What did you say, Martin?
Mute the audio. Mute. Press mute on the audio.
Or turn the volume down on your computer.
Turn the volume down.
Yeah.
Okay.
Okay, I've muted it.
Good.
Yeah.
Okay, Kathy, go ahead.
Yeah, I understand. My question really is about a project that I'm running with Ealing Community House Association. It's a project funded by Southwark Public Health, and it's a project, I suppose, dear to my heart, which is around prevention. And the prevention is a project, it came to us very late, around how to look at better public health messages to encourage older people to think more carefully about having the COVID-19 vaccination. I know it's a hugely controversial subject, but I remember very early on realising just how many Black people were dying of COVID-19, being truly deeply shocked and remaining so, particularly when I realised it was the bus drivers and so forth. And then realising, of course, that many older people were dying of COVID-19 and that a lot of older Black people were dying of it particularly. It was and remains deeply shocking. And I know that in my experience, I work at Southwark Pensioners Centre, and I see the effects of the last 2 years of the pandemic on older people who maybe have not been vaccinated or have been vaccinated but sat at home for 2 years because that's what they were told to do.
Your question, Kathy, I'm asking for a question, but we're running out of time now. I'm really sorry.
Sure. So my question is, it's really two things. One, we've got a group of equity-led researchers willing to talk to older Black people about why they don't want to be vaccinated, not to make them, but to reach out and say, please, we're looking for research participants. And secondly, what are some of the ways that we can break down those barriers? And secondly, if people don't want to be vaccinated, how can we encourage them to be as healthy as possible to avoid the worst effects of COVID-19? 3 questions, sorry, but there you go.
No. Kevin, do you want to respond to that?
Yeah, so I think this is a great project and really important that we get people vaccinated and to understand the reasons why they're not vaccinated. The autumn COVID campaign, COVID vaccine campaign is about to start shortly, and I'm going to encourage everybody, I think it's over 50 now or over 55, when you're called to go for the vaccine. But if people don't go, I think, Kathy, your project is really important because we need to understand the reasons why. We know for some people, they will say, listen, you know, I had COVID, I've been infected with COVID, so I don't think I need it. Some people still have issues of trust in what's in the vaccine, etc. But I think we need to understand the reasons today and not the reasons from 2 years ago when we started doing the vaccine work to see if there's anything more that we can do. And Kathy, your project is important as well because, you know, this summer for me as the public health director for the city has been busy, right? Because all of these infectious diseases are now, you know, we're dealing with. We have the monkeypox outbreak. We need a vaccination for that. People are getting vaccinated to protect themselves. The polio virus that we've seen, again, we're going to have to vaccinate children just to make sure all our kids are protected. So vaccines work. They're the most effective public health tool we have. So when somebody says they're not taking a vaccine, what they're essentially saying is, I'd rather not get the best care that I need to protect myself and to protect my family. And I think we need to understand why people make to that decision. To say that actually no thank you, I won't get the best care for my family or for myself, then I'm keen to understand why. So I'm glad you're able to share it this morning with us. And I think it's really good work, and I look forward to hearing the results of the study.
Thank you. Thank you, Kathy.
Kevin, can I ask you, I know a lot of people who have not been vaccinated and they're very scared of the vaccine.
Mm-hmm.
They believe that, you know, properly following other diets, or especially in our community, you know, eating this sort of way, they don't need the vaccine, you know, they're very anti-vaccine. What could we say to people like that again? Because, you know, some people are very scared of the vaccine because, you know, it's taken, we don't know the side effects of it, or, you know, if COVID's going to be, taking the vaccine could make them more sick or more better. And I think that's what scares the community as well.
Let's find out then, Kevin, for this the really important question that still bothers the community.
And also, I haven't been vaccinated, so I'm putting myself.
Well, now you've said it publicly. There you go.
Yeah.
Well, you know, there comes a point where you have to say, you know, there are going to be people who choose not to be vaccinated, and you know, the consequences of that we see, right? Because the people who are being admitted to hospital today, if they're not very old and have sort of waning immunity, they're people who decided not to have the vaccine and are playing, you know, this taking the risk with getting the natural infection. They're older. Many of them have other health conditions. Many of them are overweight or obese, but all of them are unvaccinated or incompletely vaccinated. Everyone. And, you know, there comes a point when you say, well, actually, billions of people around the world have now had the vaccine. We understand the safety profile of it. We know that it is effective at preventing severe disease and preventing you from, stopping you from going into hospital if you have COVID. I've had COVID twice, and I'm so thankful that I had the vaccine, because the first time I had COVID, it lasted 1 day, and the second time it lasted 3 days. Why? Because I had my vaccination, and it protected me from having any severe disease, and I was able to manage myself at home, a little bit of bed rest like a flu, and I was better in no time. But the vaccine gave me the confidence that when I got COVID, I wasn't panicked, because I know that it protects me from severe disease and death. I can tell you, Abina, unfortunately, God forbid, if you should acquire the infection, you would be worried, because you'd be saying, I don't have the protection of the vaccine. You know, anything can happen with me. And we see this all the time of people who come into hospital and are being treated. I'm so sorry, doc, I didn't have the vaccine. I should have taken the vaccine because I didn't know this would happen to me, all right? 2.5 years into this pandemic, people are still somehow thinking it would not happen to them, but it does, and it eventually will. And all the vaccine does is that it gives you better protection, so that when you become exposed to COVID, your body can naturally get over it without you needing to be in hospital and in ICU. So that's all I'm going to say, because we're all adults and we're going to make our choices. I made a choice, and I'm glad I made my choice, because when I really met COVID, you know, I had my family in Jamaica, in the US, everybody calling you, okay. Yes, I'm fine. I had the vaccine, I had the booster, right? I'm looking forward to getting my autumn booster as well, because I want to be well protected. I don't want to be rocking up in guys and St. Thomas's and them looking at me and saying, Prof, what is this, right? Why are you here? No. And I have my family. I don't want to be taken away from my family before my time. And that's why I take the vaccine. But those are my decisions.
Add to you before, sorry,
yeah.
Because and I really want to capture this point, because it's really important. But I know it's an ongoing debate. It's most certainly been an ongoing debate here on GalaxyFreeWay.net. There's no doubt about it whatsoever. It has split so many individuals and families and so on. Kevin has said, billions of people, not millions or thousands, billions of people have taken the vaccine. Okay. If there are side effects, the side effects versus the impact of the condition are minimal. Okay. Billions of people taken it, and what, two-thirds of the British population are now vaccinated, and above, I imagine.
Above, yeah, above.
Vaccinated. And if there were severe side effects, if there was infertility, if there were vulnerability to other diseases, if there were other conditions that were that arose from taking the vaccine, if you could track yourself through some digital devices when you're taking the vaccine, the evidence would be here now, and I'm sure those who are saying no to the vaccine will call up right now, despite the fact I didn't open the line, and will be presenting the evidence to us right now. It has not happened. Okay. And whilst I do agree the concerns in some members of the community, and I share it as well, what happened in Tulsa, okay, in Kentucky, was an abomination. Yeah, the experimentation on our people to see how syphilis spread amongst the community was an abomination. Absolutely, okay, absolutely. But I have seen no evidence, unless Kevin's going to say otherwise, of course, or everybody's going to say otherwise, of course, that there have been experimentation specifically on the Black or other minority communities of that type. Okay. In fact, with the level of presence of our peoples in the NHS, it's highly unlikely, remotely possible, because we are present within the NHS. We see all the trials that are underway. And Kevin, people like Kevin are ideally placed to have that overview. Okay. So the fears which are being propagated by some people, I don't believe have our collective interest at heart, okay, are damaging and absolutely has led to deaths in the community, unnecessary deaths in the community. And I say to all those who continue to propagate those negative propaganda for which there's no evidential basis, stop it. That's why I say to you, stop it. I can say, Kevin, let me say it. Stop it. That's what I say to them. And don't worry, Abhinav, you and I need to talk later on. But I say to everyone else, who are in doubt, okay, if you can present a shred of evidence to us to support your assertion that the vaccines that billions of people have taken around the world is harmful to us, okay, present your evidence. That's what I say, present your evidence, yeah? And have it peer reviewed. Have that evidence peer reviewed, so that we know that it's not biased and all the other professional things that fall into this. Have it peer reviewed so we know it is accurate. Okay, and if it's accurate, I'm sure Kevin wouldn't mind coming back in a year's time, because we definitely got to talk to him about the commissioning and research into cardiovascular disease, diabetes, maternal mortality, and so on. We need to talk about these big issues, which are frighteningly high figures. You know, why should a woman be 4 times more likely to die in pregnancy just because she happens to be of African or Black descent or Asian descent? There's something fundamentally wrong with that. Again, I do not accept the excuses that there's something wrong with the administration of health. There's something fundamentally wrong with the leadership of those services. So I'll come back to the point. If there's evidence, present it. Those who said it have not presented evidence.
Mm-hmm.
Okay, so that's the only comment I'm going to make on COVID-19. I want us to end on a positive note, though, Kevin.
Yes.
Okay. So, in taking responsibility for our health, okay, and I believe this and other programs have been contributing to that internal debates, particularly in terms of our cuisine and how and what we eat, how we take care of ourselves, those deliberate steps to monitor our health and take care of ourselves. I have a bit of a heart and high blood pressure meter at home. I've got my weights here. I always demonstrate this every Saturday. Weights after my run. You know, I'd like to do this because people seem to. I keep handy my water, so that ensure I drink my 2 to 3 liters of water. I'm told my doctor says that it's the right thing to do. And so on, taking those deliberate steps, and that's absolutely right. But you said earlier on there isn't more money in the system, and you mentioned good people are going through elections at the moment, and I accept that. what I suppose I'm interested to hear is your prospects in terms of the outlook you see in health in London. What do you see the outlook? For example, what will the impact of the ULAZ have on health of Londoners, as well as our own community, if we reduce the numbers of cars that are polluting the air, particularly with carbon dioxide and so on? Tell us what's happening. Tell us the prospects, and is the outlook good? Is it reasonably good, or are you concerned? But I suspect that the outlook is quite interesting, according to reports I've seen. Am I right in that assumption?
Yes, and London's leading the world in taking these big steps on air pollution. Air pollution kills. We lose thousands of people across the city every year because of air pollution. And the reason is, obviously, it's not something that you can see. Sometimes you can smell it, feel it, especially if you're on a busy road. But in general, because we can't see it, we think it's not a problem. But we know that it kills people because people with severe asthma, chronic respiratory diseases, and it causes a range of other health issues, including a link now between air pollution and your risk of dementia, air pollution and your risk of cardiovascular disease, CVD, which we discussed earlier, and air pollution and mental health. So we know that bad quality air has a lot of effects on us. And the ULEZ, which is actually extending the restrictions which are currently in sort of central London, right up to the periphery of London, is going to save lives because it will improve the quality of air that we breathe. And it will ensure that some of the more poor and disadvantaged communities, especially those in zones 3 and 4, where you have lots of car use, is also going to benefit as well. Because at the moment, it's the data from the inner core of the ULEZ is so powerful that by not having the rest of London doing it, we would be actually creating a health inequality between the inner London and outer London. Mm-hmm. So by extending it and saying, actually, here's what we need to do now, lives will be, thousands of lives will be saved. So just to say, that gives me hope that that is one thing that we can do. And when it comes to improving our health, and we have to talk about air pollution because it is the silent killer. The next thing I'm hopeful about is the conversation that you and I and Bina have been having this morning about the simple things that we can all do to take control of our health. We spoke about not being passive in organizations in the NHS. We can't be passive in our lives either. And that includes, just to add to your list, Martin, rehydration, making sure that we have 150 minutes of active exercise every week. That is something like 20 minutes per day. That is walking to Tesco and coming back, right? It is walking not to your nearest bus stop, but 2 bus stops further down, on the way to work, on the way coming back in. If you live in the central zone, when you're coming home from Soho, just cross the bridge, right? There's things that you can do which are really quick, easy to get in your 20 minutes per day of physical activity. That is what I'd like to see more people doing. The cost of living crisis means a lot of us now are making really tough choices on what we eat and the foods that we eat. Please don't go for the cheap and sweet fast foods, right? The money that you spend on a McDonald's burger, you could easily go into Sainsbury's, Tesco, Lidl, get some vegetable, a little bit of protein, and you have a healthy meal. So even in these tough times, let's resist the temptation to get on the fast food route when we can just be a little bit more creative to eat healthier. And as we said, get engaged with the blood pressure as well. And then finally, the point on vaccinations are important, because what you want to do is that you're giving yourself the best chance to be as healthy as you can, to take care of yourself, your family, and those around you who love you. This is what this is about. If you don't have your health because you're failing to do the basic things that we all need to do, that means that you may not be around long enough to enjoy the fruits of this life and the gifts that you've been given. So that's what I would like to end on.
Oh, I love that,
Very,
Kevin.
very much.
Really love
Sorry,
that.
it's 10 o'clock now. I've just been alerted, but I have been looking at my phone, and I've got many, many questions put I had a phone. I think you have to come back again. There's so many questions here, but let's just say that a number of councillors are listening, and Councillor Koto here in Centre regards, and she's loving what your health messages. We have to keep repeating your words because these are powerful messages. I've got councillors in Lewisham, Croydon, Lambeth, Haringey, apparently. Anyway, right across London are listening to you. This is a powerful message. We need to get you back. There are some interesting questions I've just noticed, which we've not been able to get to today, but messages and responses to your questions today have been sufficient for today, but this is an ongoing dialogue. I would, first of all, before you go, say thank you. Thank you for all your achievements to date and what you will achieve.
100%.
Okay. I'm confident. Abina, you want to say something? Let's say conclusion.
I think you've come on and you've informed us really, really well. I think, I've been inspired to do better. I think it's been a food for thought for me, definitely, in terms of vaccinating, sickle cell, and it makes me think about all the stuff when I go back to work, what I can do for my community. So I think you've been great today, Kevin, and it was great to find out about you and your passion for medicine and the NHS is great.
Thank you. And just to say again, thank you very much. We may have to do it in a much shorter period based on these questions. There are some
well, listen, thank you, Martin, Abina. It's always a pleasure to come here. And, I hope by me telling you some of my own personal stories, some of the losses that I've had of good friends because of simple things that they could have done to save their lives, and they're not here with me today. This is real. This is not just a job for me, right? This is not just a day salary. This is about my community. It's about the people I love. It's about being here for those who I love and taking steps. And I hope that, if nothing else, those messages came across today. Martin, thank you so much for the invitation. I know it's always hard to get me on the show, but whenever I'm here, I have such a good time. And thank you both for your leadership.
Come back again soon.
Okay.
I want to see you again soon and tell me what else you've been eating other than fish.
Yeah, you say I've not said that to you. Thank you, Kevin. You take care of yourself. We are with you. Keep doing outstanding work. Thank you.
You're good. Bye, everybody. Take care.
Bye, Kevin. Take care.
And Empress Abina, powerful. And we've got to end now. I think we're slightly over our time, but I hope the listeners take from this those positive messages. And remember, our health is our responsibility.
Health is wealth.
Health is our wealth. There's a powerful presenter here on Council Radio by the name of Dr. Stephen Ferguson, for whom that is sapline. Our health is our wealth. Thank you, everybody. Blessing. And indeed,
everyone.
We've been followed by Empress Shanice, the Solutions Finder. Oh, it'd be a beautiful program to listen to on galaxyafui.net. I recommend you stay on and listen to her. But for today, until the next strong, I remain the motivator, where we translate our words into action. And remember, success is ours for the taking. Blessings to you all. Blessings. Take care.